You can go ahead and share your screen. Okay, so let's get started. Good afternoon, everyone. Thank you for attending this webinar today titled Implementing Home Modifications in a Community-Based Setting. Our speaker today is Emily Somerville from St. Louis, Missouri. Emily is a faculty member at Washington University in the Occupational Therapy Department. She delivers home modifications and interventions for research participants with a variety of health conditions. Emily also trains occupational therapists to deliver evidence-based interventions, and we are excited to have her with us today. Emily, take it away.
Okay. All right. So like Shardana said, we're going to be talking about the implementing evidence-based home modifications and the process that comes with that. So first, a little overview for you. We're going to talk specifically about the different populations that are often involved in the home modification process and who benefit from home modifications. We will look at evidence, and we will talk specifically about the process, who's involved, what everybody's roles are. And then, like Shardana said, we'll have some time for question and answer at the end. So to start us off today, I want to set the stage for why what we're talking about today matters. There's different groups of people on the call coming from different backgrounds. So I thought we would just start off getting us all on the same page. So first, let's talk about disability. We have about 61 million people in the United States who live with disabilities, about 26% of our overall population. And then when we look into some more specific communities, like older adults, then it's higher to or closer to about 40% of people age 65 and older are living with a disability. And then when we look at what kind of specific disabilities people have, we have things like mobility impairment, cognitive impairment, hearing and vision impairment, and then just kind of some general kind of not specific disabilities, but that impact things like being able to live independently and do self-care tasks on their own. So then the other population that's important to us today is older adults. And so I know many of us know about our rapidly increasing population of older adults. And we've got older adults who are just in general, who are 65 and older. The population is growing rapidly. And then specifically the population of older adults 85 and older, that population alone is projected to double by the year 2040. So one thing that's important to know about this population is that they often experience some decreases in things like physical abilities, overall desire to complete or do activities, decreases in cognition, and then often also have increases in certain things like the amount of medications that they're taking, the pain they experience, and overall chronic conditions or disability, which is where a lot these two populations often overlap. So this combination of increasing older adults who experience different health conditions means that we have a large population of people in the United States who have difficulty performing their daily activities. The other thing that is a big threat to both people with disabilities and older adults is the risk of falling. So from our own data, we know that people with disabilities, the younger group, ages 45 to 65, about 2/3 have experienced a fall within the previous year. And a majority of those were injurious. And then about 1/3 had to go to the ER as a result of that fall. And then again, in general, that population, about 3/4 are worried about falling every year. Specifically with older adults, about 1 in every 3 fall each year. And falls are the leading cause of injury death among older adults. And then the thing that I think all know about this is that the majority of falls happen in the home. About 60% specifically for older adults are happening in the home. So why does this happen? Why do why do people with disabilities and older adults have so much difficulty completing their daily activities in the home and experiencing falls in the home? And it's because, well, one of the biggest reasons is because of this phenomenon that I think Susie nicknamed it, the Peter Pan phenomenon. So we have houses that were built with the expectation that people are never going to grow old and experience some of those conditions or disabilities that people do actually experience. So we have things like steps with no handrails, or steps that are just kind of rickety and falling apart, or slippery floor surfaces, low lighting, all of the things which make it hard to live safely and independently in the home. But why does this matter? You know, if the home is what is causing all these problems, then we could all just say, oh, well, let's just move everybody out of their home. But we know for a fact that is not what people want. We've had a lot of effort in our country to help deinstitutionalize people with disabilities, move them out of even like settings that are perceived as being prison-like, and instead helping them to live as independently as possible in the home. And then we also know that older adults want to live at home, and the majority of them do, and they've lived there for a really long time. So people want to be in the home. It's where they've raised their families. It's where they have grandkids. It's where they celebrate milestones. And so it's important that we don't just, ignore this situation, and that we actually do something about making it possible for people to be safe and independent. So one of the ways that we have worked to do this is to provide home modifications to change the way that the environment is set up to encourage and promote safety and independence in the home. So when we're not able to change the abilities of the individual, whether it's because of a chronic condition that the person's likely going to experience for their entire life, or as they experience some of those age-related changes, we're not going to be able, at least right now, we can't fix all of those things, but the thing we can fix and the things we can change is the home environment. So we do things like provide adaptive equipment, home modifications, or architectural modifications, personal assistance, referring people to appropriate services. So all under this umbrella of helping to provide support through the environment for each individual. And the good news is that we know that home modifications work. They work to improve function for people with a variety of different health conditions and disabilities. Specific home modifications or home hazard removal can prevent falls, and home modifications can also reduce the negative experiences that come along with caregiving. But probably one of the most important things of all of this is it's not just any home modification intervention that works. When we look at all the evidence overall in a comprehensive approach, there are certain criteria that has to be met in order for the home modification intervention to work, in order for it to do those things that it's capable of, like improving functional performance and reducing falls. So what we know that has to be in place is that an OT needs to be involved, and that the intervention is intensive. And what we mean by intensive is basically that it includes a comprehensive assessment of the individual's abilities, their personal abilities like vision, strength, mobility, gait, etc., and of the home environment by an occupational therapist. And then we know that the intervention plan needs to be comprehensive. It is specifically, the intervention needs to be designed to reduce those hazards or barriers in the home. And then it has to support actually completing that work. So it's not just a plan that gets handed off to an individual, but that there's actual support in that process to get the modifications or equipment, strategies, whatever, actually implemented. And then the other piece that's really important and that has to be a part of the intervention to be effective is training for the client or the caregiver, anyone involved, to actually be able to safely complete their activities using the new environmental support or modifications that are implemented. So based on these things that we know, through a comprehensive search of the literature and review of the literature, we have a process that we're going to walk through. I'm going to go through this process with everyone, and it includes these different steps that we know, again, from the evidence are crucial for the intervention to be effective. So the overview of the process is a referral or screening, the assessment, identifying and implementing solutions, training, and follow-up. So first, we'll start with that referral or screening process. So I know some people on the call are from community agencies. So sometimes the referral process, it can kind of go two different, referrals can happen from many different areas or agencies, people, et cetera. So some of the different community agencies that serve either older adults or people with disabilities, that is a prime place where you can identify those who might benefit from either a fall prevention or intervention or a home modification to improve daily activities, an intervention. So that could be like an area agency on aging, Centers for Independent Living, disease-specific organizations, even places like senior apartment buildings where people live who might benefit from this intervention. So we have a couple different tools that you can use to identify who might benefit from this intervention. Specifically, we can ask questions about if people have concerns or worried about falling or concerns or difficulties with their activities of daily living. But we also have a specific, now this is just specific for our fall prevention intervention, an algorithm that was created in conjunction with the study initiative, which is done by the CDC. So it's the Stopping Elderly Accidents, Death, and Injuries Fall Prevention Intervention. And so this specifically we designed to be used by different community partners in the community to identify people who are at highest risk for falling, and then who would benefit the most from a specific fall prevention intervention with home modifications. So that's one way that people can be identified. We also have other community health providers, healthcare providers like EMTs, who are often called to help people do things in their home or to, if they were trying to do something and then they experienced a fall and so then they're on the floor and need help getting up. Of course, doctors, if they're asking specific questions and seeing the person, noticing that they're having some declines in health or in their ability to do their daily activities, then they can refer as well. And then, of course, you can always have the individual themselves. If they've been noticing that they have changes or experienced a fall, then they can seek a referral. Often what they'll do is call back to a community agency that they're aware of that exists, that provides these things to get the referral process started. So one thing that is important to know is that you have to have a doctor to sign off on the referral. Now, that's not super hard to do. You just have to have the person's primary care physician to sign off on it for billing insurance, which we're going to talk about more in a little bit. But so the next step after a person is identified as appropriate for the intervention and would benefit from home modifications to improve their daily activities or to reduce their chance of falling, then the next thing that has to happen is the assessment process. And like I said before, the assessment has to involve an OT. That's what we know works. So how to partner with an OT can be, they can happen in different ways. So you can be an agency that actually employs an OT. And I know that there are some centers for independent living that do. And so then the OT salary can be paid by the organization themselves, however they want to set that up. You also can, there are some agencies or some that are set up to bill Medicare for the OT's time. And so that's probably not as common, but I know that there are some area agencies on aging that are set up to bill Medicare for that. If your agency does not have an OT, then you can partner with an OT from the community. So an OT who sees people in the home, bills insurance through their own company through outpatient services. It's important that it's all billed under Medicare Part B services. So the OT is able to go see the person in the home, and this allows them to bypass the whole, they have to be homebound and qualify for home health OT. This is different than that. This is an OT who bills Medicare Part B. It's outpatient therapy basically that happens in the home. And so their time is reimbursed through that. There are some organizations like Rebuilding Together that will partner with OTs as volunteers to come in and do the assessments and make recommendations. So you'll just kind of have to figure out what might work for your agency, whether the agency themselves employs the OT or whether it's seeking an OT in the community who's been trained and can bill for their services in the home. So what the OT is going to do, and part of the reason why having an OT is important, is because they're going to complete this comprehensive assessment process. So they're going to identify the personal abilities of the individual. So again, things like their vision, their strength, their mobility, what kind of chronic conditions they have, all things that are going to impact their ability to do things in their home and impact what recommendations for modifications are going to be made. They'll also use standardized assessments, and depending on whether or not the intervention is more focused on improving daily activity performance or whether it's more specifically about preventing falls, then the OT can pick which assessments are applicable to that situation. And then they'll use all the information from the assessment process and work with the older adult to identify hazards and barriers in the home and to create a comprehensive home modification plan to reduce those barriers. So that's our next step in the process, which is identifying and implementing solutions with the individual. So this is important that, again, another reason why the OT is important in this situation is that they're going to work with the older adult and provide them with multiple solutions from which they can choose. It's not a one-size-fits-all process. It's not a blanket recommendation. We're going to give everybody the same thing and hope that it all works, but instead it's a really individualized process. And one of the ways that the OT does that is by looking at the personal factors and the environmental factors for the individual. So personal factors are things like what's the primary disease causing their disability, and what does it look like? What is the clinical course of that disease? Is it something that stays steady over time? Is it something that usually gets worse over time? And then they're looking at other things like how ready are they to change? Is this something that that their son referred them to and they don't have any desire to do anything? Or is this something that they have been, waiting and just hoping that they can get some help for changes to be made in the home? And then we're also looking at what their environment is like. So what financial resource do they have or not have? What's the condition of the home? Are there other repairs that need to be made first? And then modifications can be put into place. What are the rules and regulations? Is where they live a place that they own, or and so then they have more freedom and flexibility in what can be done, or is it a rental unit? So the OT is working through or considering all of those things when making the most appropriate recommendations for the older adult. So this process, we use a form, and it goes through each of those different areas and helps us to decide, again, as OTs, how are we going to make sure that what we recommend is the best for that individual, and really is going to take into consideration their personal situation and their specific living environment. Again, it's not a one-size-fits-all approach. It is individualized, and we know that by doing that, the person is more likely to adhere to the recommendations and use them for as long as possible. So the other thing that we often do, or that we do with everybody to make sure that whatever modifications are going to be implemented, is give them multiple options of things that are going to work for them. It gives them ownership of the situation. They get to choose, which option do I like the best? That also contributes to higher adherence and higher implementation of strategies in general. So those are important pieces of what the OT brings to the table to make sure that this intervention is going to work as best as possible for each individual. There are other team members, though, that sometimes need to get involved, especially during this process where we're identifying what solutions might be possible. If it's something that's going to involve installing something, then it perhaps will have a contractor, or if it's somebody who lives, let's say, in an apartment building and there's a maintenance person who will do the installation, then that person needs to be involved as well to make sure that whatever it is that we're recommending is possible given the circumstances. If it's something bigger, then often we might have a designer or an architect involved to help, if it's going to be a whole, like adding on of a room or putting in a bathroom on a first floor, things like that, then we might have to consult with some other team members as well. And then, of course, family members or anyone else who uses the space. Sometimes, depending on the client, the individual, they might want to provide their input and insight into the situation. And so it's important to remember that there are other people who are involved in this process as well. And so those are some of the examples of other potential team members that that might be part of the process as well. So after the appropriate solutions have been identified, then the OT will work with the older adult and with or the person with disability, and then with whatever organization, and we'll talk about this in a little bit, to actually obtain and then implement the modifications or equipment that have been agreed upon. The one thing that's important too is that the OT actually oversees any of the work that's being completed to make sure that things like grab bars get installed correctly, that they're at the correct height in the correct bathroom, things like that. So they will be part of that implementing process as well. So I wanted to give you all some examples of some of the most common modifications or solutions that we've seen across the many years of doing this. So one of the most common is adding grab bars. And so it could be inside the shower, it can be on by steps, by doors, just any extra grab bar hand support for the person during, whatever activity is. That's one of the most common that we see. Another one that we see is securing rugs. So making sure that there are that they're not going to slip or trip on a rug, like if they're getting out of the bathtub or moving around in the living room or something like that. We also do end up usually doing a lot with appropriate bath and shower seating. Again, this is another reason why having an OT involved is important, because if you can see in the picture on the left, the person might say, oh yeah, I've got a bath seat, no problem. It's fine. I've got the adaptive equipment I need, but really it's not actually the most appropriate for their situation. They need a different, more appropriate solution instead. And so having an OT who has that knowledge of what's actually appropriate for the individual is important. So that's the third most common we see. Next is raised toilet seats. And so adding height to toilet seats in lots of different creative ways, risers, sometimes taller toilets. That's another main one that we see. We also see a lot of need for seating in the kitchen so that people can do things like prepare meals and wash the dishes from a seated position so they don't tire out and are actually able to complete the task safely. Reachers are another one that are important because instead of having people climbing on unsafe things to try to reach things in the cabinets, they can use a reacher or able to bend down and pick something up off the floor more safely because, and then they're not getting dizzy when they're trying to bend over and then stand back up. Another thing that is very common is adding non-slip treads to surfaces. So things like the bathtub or stairs, the edges of stairs, so that people are not slipping and sliding all over the place. Adding support to the edges of to beds, so that people have something to hold on to when they're transferring in and out of bed, and then also something to hold on to when if they're trying to move around in bed as well. And then toilet safety rails or hand support for people by toilets so that they can have something to hold on to when they're getting on and off the toilet. And then the last one of our top 10 would be lighting. So automatic lighting or just increased lighting, however that might look in things like dark hallways or down stairways, things like that. So adding lighting for people is very, very common to do. So those are some of the most commonly implemented home modification strategies that we see. And so after that, those things get implemented. One thing I want to make sure to say is that some of these things, again, are things that the OT can do and place themselves, like these automatic lights, for example. That's something that, it's stuck on the wall with double-sided tape, and they can do that themselves. And then again, some of the other things have to be coordinated with a contractor, maintenance man, or whomever to get those things done, like railings and grab bars and things like that. So after the implementation, identifying and implementing solutions happens, and the next really important thing is the training process. So the OT will visit the person again after the modifications are obtained and installed and work with the client to train them with each piece of equipment or each modification that's actually made. So giving them step-by-step direction. Sometimes it's verbal instructions, sometimes it's written instructions, sometimes it's pictures, just whatever will work specifically for that individual. And then they perform the task with supervision until they're either independent or at whatever level is, appropriate for that person. And then also, of course, to make sure they're safe and know how to use the equipment as best and safely as possible. So that can take a couple of visits. And at each visit, at the visit when the OT returns, then they can review and train with each piece of equipment, and then also review anything that was implemented from before to make sure that the person is using it well and safely and knows all the ins and outs of whatever equipment or modifications they have. So then we are kind of on to the follow-up process, some of which are the immediate kind of follow-up after the modifications are made is part of that training, where we're checking to make sure that they know how to use things, the equipment is working, and then we can provide any other necessary referrals that the person might need. Maybe they need a referral to PT, or maybe they need a referral to get some home delivered meals, or whatever it might be. And then we can also provide resources for them of things that they might want to use in the future, like a home safety self-assessment tool. That's a tool that people can use themselves to identify potential problems that they might have in the home. And it gives suggestions of ways that they could just themselves remediate any problems that environmental problems that they might be having. And then for our sessions, we usually try to come back about 3 to 6 months later to check in, see if there's any new problems that have arose, see if they have done any work, implemented any strategies on their own, review any solutions that they have obtained, and also review everything from the beginning to make sure that everything is still working properly. Again, that they're safe and independent in what they're doing. So one of the things that's important to talk about is how much this all costs. And then we're going to also talk about where can the money come from to provide this intervention. So like I said, that we have a specific fall prevention intervention, which follows this exact same process, follows the same steps. It's just that the focus, the assessments at the beginning are going to be fall prevention related assessments. And the OT is going to work to specifically remove hazards in the home that are increasing their chance of having a fall. And they'll do that through the home modification process. So the cost of that, the OT time, which again is billable and reimbursable through Medicare, was about $650. And the labor and materials together is about an average of $200. And you can see there's a pretty big range. Now, some of this labor, I would say this is where it's helpful if it's somebody who lives like in an apartment complex and the maintenance person is able to install something and not charge, or sometimes volunteers from the community will come and do installation of things. And so then it's not an out-of-pocket expense to pay a contractor. But on average, we spent about $200 on labor and materials and about $600 on OT time. And then when we looked at the intervention to improve, specifically that was geared towards improving function. It was a little bit more expensive. It took a couple extra visits, so more OT time and a little bit more on the labor and materials. The thing about both of these though, is we are, let's see if I can do some quick math, a little over, under $1,000 for the fall prevention and a little bit over for improving function. So when we look at how much money that can save in the long run, which we actually did specifically do with our fall prevention intervention, it was a 111% return on investment. So providing the modification and the equipment and the funding up front to provide these services for people is actually cost effective in the long run. So some of the other potential costs would be like if something's a bigger job and you have to pull a permit for it, sometimes there's costs related to that. Or again, if you had to pull in another team member, then that's going to add to the cost of the intervention. We did not have any designers or architects that had to be involved in any of these interventions that I showed you. And I would say typically that's more of a exception than the rule, at least in the general work that we do with the overall population. Of course, there's going to be exceptions and people who want to do bigger projects. So funding, there are some different options for funding. A lot of like a local area agency on aging, they'll have funding through things like community development block grants, federal funding. So our HARP intervention, which is the home hazard removal program, which is specifically designed for preventing falls, it is approved as an evidence-based intervention to use Title III funding for. So organizations can use, if they have that money, can use that to pay for the intervention. And again, you can have the OT's time billed through Medicare if either your agency is set up for that, or if they are an OT who does that on their own, then that can, the cost of the OT can be covered as well. Or again, some organizations have an OT employed anyway, and that's usually funded through whatever mechanism the agency is doing for that. The one spot where you're probably not going to get a lot of help other than billing for the OT's time is insurance. So insurance really does not pay for a lot of these modifications. It's pretty minimal. It could be something like a 3-in-1 commode or a hospital bed, but in general, the insurance does not pay for equipment. So insurance will, like I said, cover the OT's time, but not the equipment. So that's where other things like loan closets or disease-specific organizations or agencies are good to partner with. Grants, whether it's, research grants or personal grants. And then, of course, there's always the option to pay for things out of pocket if the individual is willing and able to do that. So those are just some examples of places where funding can come from. So like I said, we have a home hazard removal program, or as we call it, HARP, that is evidence-based, that's approved to use Title III funding for and can be delivered by OTs. So the OTs have to be trained on it first and pass, competency exam and everything. And then they are able to provide that intervention. And so community agencies can partner with OTs who have been trained to do that and then work together to deliver the intervention with the older adult or person with a disability. And then we also, as a resource in our lab, have an assessment that we use that looks at people's ability to do daily activities in the home. So it looks at things like, are they able to get dressed, get in and out of the shower, get on and off the toilet, get in and out of bed, move around the home, go up and down stairs, et cetera. And so that's another resource if people need it to have a standard evidence-based assessment that looks at people's ability and then helps identify things in the environment that are making it difficult for the person to complete their activities independently and safely. And then that becomes what the OT and individual work together on to help decrease the barriers in the environment that are making the activities difficult. So there is also just some general training that's available for OTs and contractors. There's things like a certified aging in place training through the National Association of Home Builders. There's an executive certificate in home modifications through the University of Southern California. So there are other just kind of general resources that are available as well. And then, like I said, we have specific training for OTs in particular to do fall prevention and just home modifications for fall prevention and improving daily activity performance. So I think we will stop here and have some time for questions. So let me stop sharing my screen and people can jump in and I'll look in the chat. Let me see if there's any specific questions there. Yes, you can have a copy of the slides. All right. Does anybody have any specific questions that they want to ask now?
So I'll jump in. Quick question here. So OT does the assessment. They come up with recommendations. What level of responsibility do they have after that? Let's say a family decides to take that on, or another agency decides to take on the plan. Is the OT still responsible for? I mean, say they recommend grab bars or something, but another agency does that. Are there concerns on the OT's part that they made recommendations that they don't necessarily address themselves?
Yeah, so that's a great question. And I think that kind of gets addressed in a couple different ways. One is that the OT, especially if it's something where a family member's or an outside person, like a contractor, is going to do the work, then I, as the OT, for example, would try to be there. Like I'll follow up with the person and say, all right, when's the work getting done? I'm going to come and be there when the work is getting done. If that's not possible for whatever reason, and if it's something like specific, like let's say grab bars getting installed, then I'll go ahead and mark, like in the bathroom, for example, specific spots where the grab bars need to be installed. And then I will also have a conversation with the contractor or the family member or whoever, with like, okay, hey, here's what needs to be done. Here's specific, like show them either in pictures or tell them, hey, here's where the grab bars need to be installed. I've marked it with tape. So I just make that a communication kind of part of the whole entire treatment process. So yes, I guess there are times when people can go rogue and there's nothing I can do about it, but I kind of set the expectation at the beginning that this is going to be a partnership, that we're going to work together, that I'm going to be here and be part of this process of actually getting things implemented. And then when they do get done, then I'm going to follow up as well to make sure that they use everything safely. So I guess the short answer is, yeah, that the OT is definitely involved, and it might look a little bit different, but with each person and contractor and whatever, but as much as possible that they're definitely involved.
Thank you.
Mm-hmm.
I have a question about, I have a question about Medicare and
Yeah.
So with OTs, you said some OTs can bill Medicare directly. So we have a home mods program at Mark for older adults. And when I took it over, like it had really shifted to being more of a construction focus, and we were doing a lot of like roofs and plumbing and electrical and not so much like the aging focus. And so I was like, we gotta like dial this back and figure out how to get this more safety and fall risk prevention focus. But it's kind of hard to figure out like who could administer that fall risk assessment. And so like I'm repeatedly seeing this emphasis on the OT's role, and I appreciate that. And so my solution was like students, maybe because the one of the great OTs in Kansas City that does a lot of this in-home work with older adults, I was like, I don't know how we pay for her. But she didn't even mention that like she could bill Medicare for these clients. So like, what would that look like in the beginning? Would she sit down with them and say like, I need your Medicare information, and then like get a referral from your doctor so that I can...
Yeah, so that's there's a couple things I want to, don't let me forget to talk about students, because that's a great point too. So if it's an OT who is not who in like your situation, it sounds like is, would she be like self-employed essentially?
Yeah, she has her own company.
Yeah. So if they have their own company, then or you would want to partner with someone who has their own company, they would be in charge of the billing themselves. Now, I'm sure there's examples of places, and I think there are some AAAs, for example, that do Medicare billing. But by and large, when you partner with a community-based OT, they're going to be doing their Medicare billing. So essentially, there'd be some kind of referral process where you would say, okay, I have this older adult who I know is worried about falling. I've screened them. They have difficulty with walking or whatever, And so then you would refer them to whoever that person is and your OT that you're talking about. And then they would take care of all of the billing on their end. And they would have to get a script from the doctor to be able to do that, but they would then that OT. So you wouldn't actually be you wouldn't be responsible for paying them, and you would not be responsible for billing. So it's like two partners working together. You're basically their referral source, but then you're also, in theory, if you guys have funding to provide the modifications, then you're the ones that are going to be, once she comes up with the plan, then you guys would work together to actually implement the plan with with her. Shoot, there was something else I was going to say about not students, but well, if I remember, does that answer that part of the question?
Yeah, so I'm thinking like that OT would need to like sort of agree to with the AA on the kind of mission, like, hey, so we're going to do 6 to 8 visits. I mean, that's a lot, but like I forget what
Right.
your recommendation was, but we're going to do a series of visits so that we can
Yep.
kind of ensure compliance with recommendations. And like,
Yep.
so we kind of have to. Okay.
And in that situation, especially if it's related to fall prevention, then that OT can get trained in, like, for example, in our fall prevention intervention, that's 2 to 3 visits. You know, it uses a specific assessment process, it follows the same process, but I kind of gave the general overview, and then there's more specific with the fall prevention intervention. Here's the assessments you use. Here's what you do at session 1. Here's what you do at session 2. And it's really only 2 or 3 visits. And then, but yes, so they would do that, and they would partner with you to be able to provide the modifications that they would be recommending.
Okay.
I remember the other thing I was going to say is it is different, and there are some organizations, again, that do get funding to pay an OT, to have an OT on staff. But it sounds like that's probably not what the situation that you're in. And so then the best option would be to collaborate with a community-based OT to provide those services. But the other thing you mentioned were students, and students are a great resource if you have a school, an OT school nearby. We do that a lot. We try to do that with our students. We specifically will take fieldwork students. So like OT students are doing a clinical rotation with us. And they will be, and I can see the question about liability. So let me answer that while I'm talking about this. So basically, if I have a fieldwork student, for example, they're practicing under my license, I'm supervising them. I go out, do their, train them on the assessment and intervention process. I have to sign off on all their treatment planning, et cetera. So it's really my license that is kind of absorbing the liability, which is a normal thing. That's what we do with students, but they would have to have a practicing OT as their supervisor. So if you're looking to partner with like a school that has OTs, an OT program, then that could be a way to do it. Is they bring in fieldwork students. And I say fieldwork students because those are students that are, it's their clinical experience. It's their training right before they are going to go be independent on their own. And so they're at the point in their schooling knowledge, et cetera, that they could actually know what they're doing to make recommendations and work through the whole process with them. So that's definitely an option. You just would have to partner with a school to make something like that happen.
Yeah, and I think so we have, right, this is like just testing the waters. And so we have OT assistant students who are doing like 25 this fall, and then Rockhurst program is a full program, and they're supposed to do like 25 in the spring. And I will say, like, as I'm watching this, like the challenge is they can't really do this like ongoing part. Like they are doing like the assessment, and then it's just way too complicated to try to, and way too drawn out to like have invoicing, referral, intake perspective, like to do all those, to make it a longer thing for the students. So
yeah,
that's why
typically if we have fieldwork students, it works, the OTAs, it works fine for, but they just are usually here for a shorter amount of time. So you're right. It usually, if we have fieldwork students, they're usually with us for 3 months. And so then they have time in that 3-month process to go through the whole process with the person. So they can do the eval, they can do the recommendations, they can help oversee and make sure they get implemented correctly, and then training. And overall, that takes that whole process should only take, well, between a month, 4 weeks and 6 weeks. I think it just depends on, usually where we get slowed up is with the obtaining equipment, implementing the modifications, et cetera. So it's usually 2 or 3 or 4 visits over the course of a month or so. So it doesn't, once all the kind of kinks of the process are worked out, it's not usually a super lengthy process. But again, sometimes it gets tied up in, contractor availability, or a piece of equipment is on back order or something like that. But in general, it's about a 4-week to 6-week process. Any more questions from people? Oh, installation liability. That is a great question. So basically, whoever it is that's installing will have the liability. So if it's a contractor that is either employed through the community organization or a contractor that they contract with to do the service, they have to be licensed, insured, all that kind of stuff. So whatever that is important, and they would take on that liability through their own insurance and that kind of stuff. Or if it's like a maintenance man through an apartment building, then again, same thing. Then they have their own liability and everything. And then volunteers, yes, volunteers will often do the installation. That's a great point. But same thing, like whoever they're volunteering through is usually who takes on the liability. So if it's like Rebuilding Together, or here in St. Louis, we have a big company, Ameren. They have random volunteer weekends where people from the company, it's our electric power company, but they take the liability. So it's definitely something to consider, but it's something that you want to make sure has been thought through. But it's typically whoever's doing the installation should have the liability insurance and all that kind of stuff. Question about OTAs doing the training visits. Yes, that is absolutely. I'm glad you asked that question, because that's absolutely a way that we do this often, is that the OT will be the one to go in and do the initial eval and treatment planning. The OTA will do the intermediate visits with the training and oversee the installation, depending on their comfort level and everything. And then the OT will come for the final visit to make sure everything is good to go. They're trained on everything. The plan has been implemented, kind of like that discharge plan or discharge visit. So it's also a great way to be a little bit more cost effective. So it's not as expensive to employ a COTA, or they're reimbursed at a little bit less of a rate. So you can have an OT to do the eval and the discharge, and then an OTA in the middle. And that is absolutely a great way to do it. So, and it's smart from a budget perspective as well.
Anyone else have any questions at all? You can post them in the chat or say them out loud. If not, thank you so much for attending today. We will be posting this recording on our website, and we'll send the link. Those of you who requested the slides, if we don't have your contact information, go ahead and leave it in the chat. I noticed some of you have already done that. We will email you the slides in the next either this afternoon or sometime tomorrow for sure. But thank you for attending, and we appreciate your time, and have a good day. Thank you.